So I want to welcome everyone to our monthly endo support group. My name is Jeanette Rodriguez and I'm the program coordinator at the Riverside Medical Clinic Charitable Foundation. First off, I'd like to thank our wonderful sponsors, the Riverside Medical Clinic and ADV, for all of their support. And before we begin, I just want to do a double down the checklist. So for those of you that are just now joining, which is a few of you, if you can hear me and if you can see me, as well as Dr. Jeff Arrington, go ahead and give me a yes in the chat box. I just want to make sure you all are able to do that. And then, of course, we will be using the chat box for our questions, so feel free to type in your questions in there, and I'll make sure they're answered at the end of our webinar today. Also, for those of you that need closed captioning, that is should be ready to go for you today. So you'll also find that in the toolbar. So we are having that ready for you. So you'll have to click that and go ahead and open it on your end and start that. Make sure that you have it. I won't have it here automatically on my screen, just in case you don't want that on. So if you do want the closed captioning, that is a feature that you can use today. All right, so I would like to introduce our special guest that we have today, Dr. Jeff Arrington. He is a widely recognized expert in advanced excision of endometriosis and minimally invasive gynecologic surgery. His knowledge and surgical skills, combined with his passion to advocate for those with the disease, have helped countless patients find hope again and restore their quality of life. His dedicated insight and compassionate nature makes him a leader in endometriosis care. He understands the frustration, hopelessness, and fear that many individuals have experienced as a result of the disease, and he is prepared to help. So without further ado, I will go ahead and give the floor to Dr. Arrington. And before I do that though, I'm going to go ahead and pull up his PowerPoint so he is ready to go. So give me a second. All right, so go ahead and take the floor. It's all yours.
Okay, yeah, and again, somehow reach out, let me know if for some reason my feed is choppy, but I tried to choose the busiest possible slide I could for my first one, and hopefully I achieved that. Now looking at it, it's got a lot going on. Informed consent, especially in the context of endometriosis, has been something that has been on my mind for quite a few years. Most recently this year has been, I guess it's kind of taken the forefront to me, but really this was not really driven in my mind from my experience, but driven more as I've consulted with patients and had patients come see me. It's been an understanding or an eye-opening to see how these patients have been walked through the world of endometriosis care, and the information or the treatments that have been tried, the information that's been given, and really noticing a lack of true understanding from these patients, and also the lack of information shared in order for them to make what I consider to be a well-informed decision. I won't say an appropriate decision, because that will be different for every patient, but I think it is impossible for a patient to make an appropriate decision without true information, education sufficient enough to give an informed consent. So let's go ahead and move to the first slide. In order to really know, how to approach informed consent, it's important for us to understand what it is. And really the bulk, if not all, of the slide presentation portion of this has been taken from an ACOG, American College on Informed Consent, that was ratified or re-ratified in 2015. And their definition, or brief definition of informed consent, says a process of communication that enables the patient to make an informed and voluntary decision about accepting or declining medical care. Very straightforward. The key part of that is really there needs to be a communication, and it's not just the doctor sharing or the provider sharing what they feel are the best options or appropriate treatments, but it is a back and forth communication where the provider listens to the patient, listens to any concerns, listens to their history, and learns about where they are going, what they want to do, or what their goals are, and then takes that medical knowledge from the different treatment approaches, and be able to So principles of informed consent, and I'll let you know kind of when to click as we go through. Principles of informed consent. The first is it is an ethical requirement. Before a provider can give a patient a treatment, whether that's medical, whether it's surgical, whatever it is, there needs to be an explanation of what that is, what the risks, the benefits, alternatives, and indications are. And that's just something ethically that is required. Next point. Next point is that it expresses a respect for the patient as a person. So as a provider, as I take the time to go through and present all of these different options, that allows me to share with the patient that I understand you may not know or may not be educated about all the different possibilities, but I trust that with the proper education, with the proper knowledge, you alone can make the appropriate decision of treatment for you. So it allows the patient to know that me as a provider, I respect you. I understand that your experience is your own. Let me give you some information to help you make the best choice for you. Next point. And again, this protects the patient. It protects the patient from treatments that the patient may not be comfortable doing. So as we do that, provide the informed consent, again, it just helps them avoid treatments that they don't want to do. In the world of endometriosis, we see all the time patients who we present options for hormone therapy, different treatments, but there are some patients who either medically can't take different hormone therapies, and there's some that just don't want to. And certainly we'll get into this a little bit later regarding, the potential for hysterectomy use in endometriosis, but it's there for the patient to understand what those options are, what the risks are, and also what other alternatives are in order for them to choose what's best. Next point. Again, this provides an opportunity for active involvement of the patient, for the patient to take control of their own decision making. And again, with the information, appropriate education can be actively involved in their treatment, in the treatment they choose. Next point. And again, the mutual sharing of information, this facilitates the patient's autonomy. So as the doctor shares information, the patient can share understanding, the patient can ask questions about different options. And again, it helps promote that idea of patient autonomy. Go ahead to the next one. And so comprehension or understanding the different treatment options, as well as the ability of the patient to make a free consent, that really is what brings in the self-determination, where the patient is the one that gets to determine the course of action. And we can go ahead to the next slide. So a true informed consent is freedom from coercion, freedom from manipulation, freedom from infringement on bodily integrity, and it's freedom from being acted on by others without respecting the individual's own preference and choice. And I believe there's another point at the bottom of that. Go ahead and hit return. And medical recommendations, they can be given when they are not coercive or deceptive. So there will be providers, as you talk with different doctors or providers, they'll give you their opinions most of the time, or they'll give you guidance, or this is what I think may be the best option, and that's okay. Often patients will even request that information. What do you feel is best, or what do you feel I should do? It's okay for a doctor to share their experience or their patient experience and give what they feel may be the best option or the best 2 or 3 options. as long as they are not coercive or deceptive, as long as all information is shared and still allowing the patient to make their own decision. And we can move on to the next slide. So these are the provider's ethical responsibilities. Hit the first one. Again, there needs to be accuracy governed by the ethical requirement of truth-telling. I hate to be too critical, but this in general is one of the biggest problems that I see as a provider when I talk to patients. The information that they are given from their providers over the course of their years, the accuracy of the information must be governed by the ethical requirement of truth-telling. And I don't want to imply that all doctors are purposefully telling lies about the different treatment options. Certainly, there are probably some out there that do that to promote what they feel is the best. But there are also a number of providers who just share what they've been taught without ever really stepping back to think or consider or look at the literature. And so the truth aspect of it, truth is truth, whether or not a purposeful lie is telling or if it's made out of, quote, ignorance. Meaning not understanding what the literature tells us or not understanding what the studies actually show. So next point, ethical responsibilities should be guided by what is common practice, and we call this standard of care. Common practice in an area, common practice within a specialty, common practice as established by a governing body. So this needs to come into the discussion, even though in endometriosis, as far as I can see, and I've published some, not necessarily not journal published, but social media posts and sent some concerns to the ACOG body themselves about my concern about the standard of care for endometriosis. That even though doctors and providers throughout different areas will look at the standard of care as established by ACOG and by their local community, I still think that standard of care falls far short for what patients should expect in endometriosis care. And I've made the comment before that standard of care is not limited by knowledge in endometriosis. It's limited by providers' ability in some cases. Certainly the cases when we look at extensive excision and treating bowel endometriosis, the established standard of care in the community is hormone therapy. But that standard of care is limited by the provider's comfort level and training to actually provide an excisional approach for that disease. We can go to the next point. The needs and it needs to be presented in context of the needs and expectations of an ordinary individual. So even though we're talking with a specific individual patient, the discussion does rely quite a bit on what an ordinary individual would need to know in order to make that decision on the guidance that the patient would need, an ordinary patient would need to make an appropriately informed decision. Next point. And again, we need to consider the unique needs of an individual patient. This is something that must be stressed in endometriosis care. Every patient's goals are not the same. Some patients are fine with pain control. Some patients are fine even with having relatively routine pain, as long as they can be reassured that overall things look okay. There may not be a critical risk. There may not be a life-threatening risk to any of this. And then other patients do need to consider the fertility or want to consider the fertility impact of either treatment or non-treatment with this disease. Next point. So provider requirements and limitations. This point is, to me, critical, especially in endometriosis care, that as a provider talks with the patients and presents all the different options, there is an obligation of the provider to be current in their knowledge, in their own knowledge about treatments and the disease processes. And they need to make clear that continued medical care is not contingent on making the choice the physician prefers. There are some limited exceptions with that. But going back to the first one, there are many doctors who or providers who will give treatment options to their patient based off what they learned clear back in residency. I think medical school, we all kind of get a general understanding, but most of us, our treatment for endometriosis is based off what we learned in residency. And often the community providers that treat endometriosis are not trained in complex surgery. They're not trained to know the different ways to treat bowel endometriosis, to treat bladder endometriosis, or to manage endometriosis around the ureters. And so when they give their informed consent or explain options to the patients, often it includes a phrase similar to, it's too risky to treat here, it's too risky to treat endometriosis on the bowel or the bladder. But that is based on their own limited knowledge and not the full knowledge that we know and have learned about treatments and the disease process itself. They also must be current in their own knowledge about how the disease behaves. And endometriosis is really variable, but it is also very unpredictable. That for some patients, pain management with hormone therapies to keep their pain and symptoms controlled may be adequate, but there are also patients who are put in that realm of long-standing year after year hormone therapy that then end up later in their years to be found to have fertility stealing, horrible advanced, what I call destructive endometriosis. So the provider must be current in their own knowledge about the different treatment options, and those treatment options cannot be limited to what the provider knows and what the provider can provide themselves. We see that in so many areas of medicine with cancer treatments and things like that. A regular OBGYN, for the most part, would not ever dream of treating a patient with ovarian cancer or endometrial cancer. They would recognize that their practice and their skills are limited in the treatment of that patient, but they know that there are those beyond them who have extra training, who have extra ability, that can provide a higher level of care or can provide options that they themselves may not offer, but are still valid and viable options. And providers need to be willing to share those options with their patients. Just as a separate example from not necessarily related to endometriosis, but my fellowship training was primarily in laparoscopic management of pelvic organ prolapse, uterine prolapse, bladder prolapse, those things. And I had some limited training in vaginal correction or vaginal surgery for those conditions, but primarily after coming out of my fellowship, I was primarily a laparoscopic pelvic prolapse doctor with relation to pelvic organ prolapse. But when I would sit down and talk with a patient, we would talk about the options of doing nothing. We would talk about the options of different mechanical ways to correct the prolapse. And when we got to the surgical discussion, I would let them know what my approach would be. I would let them know where my training and expertise is. But then I also knew that I had a very good pelvic organ prolapse group at the local university who did a great job with prolapse surgery done vaginally. So we would go over those as an option and the pros and cons, and allow that patient to gain the information to make the best decision. So even though I considered myself an expert in one method of surgical correction of pelvic organ prolapse, I knew that there were other ways to do it. And I knew of other groups or other providers who were very good at those options and make sure that the patient had the information to make the appropriate choice. Last point on this page, providers also have free choice and may decline care they deem medically inappropriate and ethically objectionable. And we will see this sometimes in endometriosis care. I as a provider, also have the right and ability to make choices regarding what I feel comfortable providing to a patient. That could also be combined with, I don't feel comfortable with this. I would treat it this way. I think this might be a dangerous way to do, or not a great way to approach it, but I have this other doctor that might be willing to listen and might be able to and offer the option that you're choosing. But just to make sure that we all know that all of us have choice in what we do. Patients have choice in what they choose as a treatment option, but doctors also have choice in, sorry, I'm trying to call through. Am I still there? but they have an option to decline treatments that they feel are ethically objectionable. We can go to the next slide. Conscientious refusal. If a provider gives refusal, they must still provide the patient with accurate and unbiased information about the medical options and then also make appropriate referrals. This is critical in the world of endometriosis. There are many doctors, and I've heard from other doctors who understand how I treat endometriosis. They don't agree completely with how I treat endometriosis and the aggressive nature that I treat from an excision standpoint. And I've heard from patients, and I've heard in notes that, and in meeting discussions when we're debating drafting documents for healthcare organizations on how to approach endometriosis, there are doctors who really feel and talk negatively about an aggressive excision approach. But when they are talking with a patient, the provider may refuse to provide an excision surgery, either based off their own feelings about excision surgery, or more often about their comfort level and skill level of the surgery. But it still falls within the realm of informed consent for them to share that information with their patients, to say, hey, I may not be able to offer this, I'm not comfortable offering this, but here's a provider, or here's a place where you can go to gather more information or to seek a more advanced approach than what I'm able to give. This is a major problem in the world of obstetrics and gynecology when it comes to endometriosis care. We can go on to the next slide. Can't remember if there are more, if that's it.
That is actually it.
Yeah, that might be it. So just a couple quick points, of things that I'd like to go back and hit. That's the main presentation, just from the ACOG article on informed consent. Again, the key to informed consent is patient knowledge. The patient needs to have an understanding of what's going on, what all the treatment options are, and not only the risks of treatment, of choosing that option, but also the risks of not choosing that option. With endometriosis, doing nothing or observation is an option, but the patient needs to be aware that by choosing this option, the risks that may be involved are continuing pain. There could be progression of disease or destructive. Sorry, people keep trying to call through. And progression of disease to a destructive point where it can destroy hopes and dreams. It can become more invasive into organs. So they need to understand that there is also a risk of non-treatment. That comes into the role of medicines to treat endometriosis. And I tend to lump all medicines in endometriosis in the same category as symptom control, or what I call a palliative role, where we can focus on controlling the symptoms, understanding that there is a risk that we are not controlling the disease. Within another ACOG document, they make the statement that there's no data to support the idea that hormones prevent progression of endometriosis. And as a provider, am talking with patient about different hormone options, that needs to be part of my discussion, so the patient can understand that, yes, I may choose a hormone approach. And I understand that if my pain is not controlled, then I may need to try something else. But if my pain is controlled, I need to be aware that the disease can be progressing while my pain is being controlled. And for some patients, that's too big of a worry. What I hate to see is patients that have been tried on all these hormones, and even some that have done very well on hormones. And then they finally get to the point where they have an official endometriosis surgery, say mid-20s or later 20s, that sort of thing. And by the time we finally get there, it's been a destructive form of endometriosis where their fertility is severely at risk. And those are things that they were not told when they said, well, let's just put you on this hormone pill right at the very beginning. When we talk about being able to understand risks and use those to make an informed decision, those risks need to be based on fact. It cannot be based on a provider's own personal feelings about it. It cannot be based on the provider's lack of knowledge on that. And we see that all the time in patients where their doctors, either they'll be shooed away, or you know, you don't want excision because it's too risky for adhesions, or it's too, you know, they give general negative talks or negative points about the role of excision without really being able to explain what those risks are. Certainly for adhesions, we all know that adhesions are a risk with any surgery, but those of us who do advanced endometriosis also understand what those risks are, and we take steps during the surgery to really limit the risk of adhesion formation, whether it's tight bleeding control, whether it's different adjuncts that we use to prevent adhesions, sometimes ovarian suspensions, different methods that we use to try to limit the risk of the adhesion formation. And then also, we really see this in cases of really advanced, say, stage 4 frozen pelvis or bowel involvement, where providers will go in and they'll just see everything completely, you know, frozen in and stuck in, and they pull back out and just say, look, your only option is Lupron or a hysterectomy. And then if a patient asks, well, what about excision? What about sending to someone who might have more skill or ability? And they'll flat out tell them it's just too risky without really sharing what that risk is. Specifically with bowel, they'll just tell them, look, it's too risky to take endometriosis out of the bowel. You know, you worry about an infection or a colostomy. You know, you'll just go in and have the surgery, have the bowel removed, and end up with a colostomy bag, without really understanding that it's extremely rare for a patient with bowel endometriosis removal to end up with a colostomy bag. Almost, not quite, but almost never do they wake up from the original surgery with an ostomy bag. And for those who do end up with an ostomy for a healing complication or a leak, typically that's temporary. And these are things that are not shared with the patient. It's just a blanket statement, that's too risky. And the patients take that at face value without real understanding of what those risks are to allow them to make a decision. One of the most critical and I think most urgent things that we see with endometriosis informed consent is the idea of hysterectomy. And I think all of us know, and I can't even begin to share the number of patients who've been told that, like I mentioned before, with advanced stage endometriosis, your options are Lupron or Orlissa, or a hysterectomy, or get pregnant. And they're given those three options. There's no mention of the possibility of referral for more advanced surgery for the endo. And they're either with stage 4 endo or known scattered endo, and their providers tell them, well, we just need to go in and do a hysterectomy, and that's definitive treatment. And they're, you know, with that, endometriosis can't be a possibility once the hysterectomy is done. That discussion about hysterectomy being definitive treatment for endometriosis is not based on any science or any data. There's nothing that shows anywhere in the literature that hysterectomy magically makes endometriosis disappear. Some patients will have a better pain outcome combining hysterectomy with endometriosis removal, but the idea that removing the uterus will magically make a disease disappear that by definition grows outside of the uterus, that's one of those things where there's a false statement given in that informed consent. And there are a number of patients who have been harmed by that. Now with that, for the most part, I think it's hard for me to blame the providers that share that, even though they're the ones that are sharing that information. They're sharing what they have been taught in residency, and they're actually sharing what they read in the ACOG document, in the ACOG practice bulletin on treatment of endometriosis. They use the words, many consider hysterectomy as definitive treatment for endometriosis. And they throw that out there without any science or data to back it up. And all the providers here is that hysterectomy is definitive treatment. So patients are then told, well, you've had a hysterectomy, your ovaries are gone, there's no way that it can be endometriosis. And then they're just stuck wondering if they're crazy, they're stuck doing pelvic floor physical therapy, they're stuck going to GI doctors, they're stuck going to pain management, when there's documented endometriosis in the pelvis that was not treated. That is a critical error in our current informed consent regarding endometriosis treatment. Those were the main kind of extra extended points I would like to make. And just maybe like to open it up to you, Jeanette, or if there's anything else that's come through, we can take some time with the idea of informed consent, just to throw out there.
I really don't feel it's appropriate for me to comment on specific instances of patient-specific informed consent concerns or issues, because I do not know the full story. In general, these are the things that I've talked about, but with informed consent, we do get into kind of a medical legal type of aspect that we've just got to be really careful without knowing, without knowing specifics regarding what was discussed and all that sort of thing.
Yeah, no, that's all great information. Thank you for sharing that. Yeah, and so just as Dr. Arrington mentioned, I'd love to open up for questions. I think this is a great topic that a lot of the endo sisters are always interested in learning about, and how to appropriately, probably direct questions, right? So for those of you that are interested in asking, please feel free to use the Q&A box, or if you want to add it in the chat box, feel free to do so. We do have a couple questions. The first one that I have here: how do you suggest to approach a GYN who is refusing to provide a referral to an excision specialist?
For me, I would just say, look, you've presented all the options that you're aware of, the ones that you think are best. I know that there are opportunities and providers who can offer excision, who maybe have more experience with endometriosis. And even though you don't agree with it, or you don't feel that it's a good option, I still feel like it's an option that I want to look into. And that I would present it as, I know it's an option, but I personally would like to gain more understanding of that and have a consult, just so I can make a decision on what's best for me.
Yeah, I think something that I really appreciate from all of the endo sisters is that they're very knowledgeable about.
Very much so.
Yes, and I think it's important that they also become very well informed. And that leads into my second question. How can a patient do their due diligence in getting the proper information to make a decision, especially for newly diagnosed patients?
Certainly there's going to be a lot of self-education internet searches are all over the place. There are a lot of advocacy pages, Facebook, Instagram, just advocacy groups that have really kind of educational type documents, as well as reaching out to other patients and endometriosis advocates to gain the information. And then they will be more prepared when they go in to talk about different treatment options. We find a huge number of patients that finally they're able to talk their doctor in, or their doctor consents to doing a surgery. They go in and diagnose the endometriosis, but they either don't treat it and then put them back on the hormones, or they partially treat. But as long as the patient understands what some of those options are, they'll be better, more prepared to go and advocate for themselves, because we know just based off the way endometriosis is treated, that there are many doctors who don't know what treatment options are. There are many who basically feel like they need to run through a gauntlet of hormone therapies before they would ever consider surgery. There are some doctors who just say, look, we just need to wait until you're ready to get pregnant, and then we'll do a surgery. For me, even if it's a teenage patient, for me, I feel it's important to have the patient and their parents, or whoever the decision makers in the process, to still cover all of these options. And for a teen patient, it still may be very appropriate to say, hey, let's try a short time of hormone therapy to see if we can at least allow you to be functional, as long as we have a reasonable idea that this is not a destructive form of endometriosis yet. But I still talk with them about the possibility of excision, what the pros and cons of that are. That I feel that there are certain forms of endometriosis in teenage patients that still may be very early that they're harder to see. And in theory, that could increase the risk of finding disease at a later date, although I don't have the studies to back that up. But it's still, even in a young patient, I feel that all those options still need to be presented so that they can make that decision.
Yeah, The next question that I have here is, do you think there could be a role for the endometriosis patient and advocate movement in assisting to educate patients in their rights and consent?
Certainly, and honestly, I think in the form of patients and patient advocates, they get a lot more information regarding endometriosis in that forum than really I think they do with their providers in a general sense. And that's unfortunate.
Yeah. The next question that I have, we have a lot of them coming in. Great. The question is, what are the patient's rights if they had a wrongfully done surgery or have side effects?
Honestly, that gets a little bit beyond that gets into a legal expertise, which I'm not trained in that aspect. I think if there was surgical harm maybe that wasn't disclosed, or treatment effects of treatment that maybe weren't disclosed that are common enough that probably should have been disclosed. I mean, there are risks to any treatment that we do. And if you pull up a medicine and list that, and pull up the list of adverse effects, you're going to see a list that's a mile long. There are some effects or complications, things like that, that are more common than others. I think it's unreasonable to expect that a provider will be able to list everything from the most common to like maybe one or two of these have happened. So as providers, we take in general the main risk, the most common risk that we see, and should present those to the patients with the idea that there's an understanding, or present that well enough that they can understand. We see a lot of patients who are told or put on Lupron without a whole lot of information, or even put on hormones without a lot of information about what the long-term consequences could be of only focusing on pain management. But specifically with the Lupron comment or Lupron prescription, I think there needs to be a discussion about bone health. I think there needs to be a discussion about the hot flushes, probably a discussion about ovarian suppression and sometimes even prolonged ovarian suppression. But more often than not, patients are just told, don't believe everything you read, without having that appropriate discussion.
Thank you. The next question that we have here, are there any current movements towards changing that base level thinking of OBGYNs that are being taught?
Certainly there has been a movement for a very, 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 very long time. Both patient advocates who are intricately involved with ACOG, those who have been talking with, and ACOG really is the one that kind of sets the initial standard. Residency programs draw on ACOG a lot in their teaching. I remember as a resident that when we would be required to present topics to a grand rounds, most common place we would go for initial information was the ACOG bulletins to see what ACOG presented. So there has been a long-standing work of people trying to get into ACOG's ear and help them know and understand that there at least needs to be a discussion regarding excision surgery. I feel that there needs to be a serious talk about promoting hysterectomy as treatment for endometriosis, as well as an honest discussion about what the role of hormone therapy is in endometriosis. There continues to be pushback from the advocates. There is equal, if not more, pushback from ACOG against the advocates. I don't have a full understanding of why that occurs. I've expressed my feelings privately in an email to some of the ACOG board. It's a huge battle, and I've said for years, we've had providers that discuss it. We've had patient advocates that have discussed it. I really think that it's going to take a patient-led movement in order to move the needle on it. And that, again, that's unfortunate.
Yeah, and I think that answered one of the questions that was asked. So thank you for that. Another question that I have here is, do you recommend going to an excision specialist for both diagnosis and treatment when endo is highly suspected?
I think that with that, I think to me, it gives the best option. If a patient is willing to undergo surgery, I feel that gives them the best opportunity to fully treat the disease and try to limit the need for recurrent surgery. Not only in recognizing endometriosis and the atypical presentations of endometriosis, but also knowing you're going somewhere that they are comfortable and able to treat endometriosis wherever it's found. But I also understand that there are not enough excision specialists and it's not recognized enough. And the insurance game comes into it and the cost of surgery comes into it. And I fully understand that. And I think that there can be benefit of some patients to seek a more logistically reasonable approach to endometriosis surgery and maybe go and have a surgery locally. If nothing else, it can make the diagnosis. And if the doctor is willing to provide pictures and do a really thorough evaluation, that initial surgery can give information that can then guide the patient and give more information. We do, although in my hands, I don't feel there's any benefit at all to a diagnostic surgery for endometriosis. But in a patient who just doesn't have that option and needs more information, that can be another piece to the puzzle, just like a CT scan or an ultrasound or something like that. It can be a piece of the information that then gives that patient more information to use to make a more advanced decision.
Great. And then there was a second part to that question. Going back to the first part, would the excision treatment be something that would help avoid multiple surgeries for those that might be going through a time-sensitive issue due to age or fertility?
Right, and my answer to that is yes. To me, that is or should be the easiest outcome marker that we should be able to pin down for endometriosis. Patients often talk about recurrence rates. I personally feel that recurrence rates are very difficult to pin down. Recurrence requires a second surgery. It requires a second surgery that then goes in and looks and is willing to evaluate for endometriosis or not endometriosis. It's easy for us to see, okay, if a patient had an excision surgery, did that patient have to go back and have another surgery? And before coming to Georgia, I worked in Utah for 14 years. And I was part of a panel of one of the large healthcare hospital systems out there. And as part of that, I had access to their data and I was able to pull my personal data over an 11-year period. And during that 11-year period, I was then able to take that and look at the patients who, if they had a surgery with me, what was the risk within that system that they had to go on and have a second surgery. And I was able to capture those who had surgery with me or any doctor within the 12 hospital system. And it allowed me to look at that. And when we pulled the numbers, I was able to get nearly 90% of my patients that did not have to go back for second surgery for endometriosis. And to me, there's value in that. It doesn't tell the full story. That doesn't infer that every patient, that 90% of patients that had endometriosis excision were pain-free or completely pain-free. But at least it gives us a marker that 90% of those patients were not in that, what we call the revolving door of the OR, where they're going back every 1.5, 2 years. We'll see patients 7 surgeries, 15 surgeries, all that sort of thing. I feel that an early excision and a good approach or attempt at complete excision can limit that return to the OR risk.
Oh, that's great. Another question that we have here, do you have any suggestions for language to use on how to tell them that, I think what they're trying to say Okay, so maybe I'll read the very beginning. As an endo advocate, others will share with me they are going to get a hysterectomy for their endo. Do you have any suggestions for language to use on how to tell them that won't treat it and they need to see another doctor without becoming angry, without becoming an angry encounter?
For me, I think that the easiest way to approach that, again, it's not to try to convince them. It's just to make sure that they have the information that they need to make an informed decision. They're still the ones that get to make that decision. But I think the easiest way for me to approach that is just to say, look, by definition, endometriosis occurs outside the uterus. And it logically does not make sense that by going in and removing the uterus, that all of the other endometriosis is just going to disappear. It doesn't do that. Hysterectomy may be appropriate, but I think in the realm of endometriosis, it needs to be combined with treatment of the endometriosis that's there. Some patients will do okay just by removing the uterus. But I think it is most likely something where there was a uterine cause of the disease, either in the uterosacral ligaments that removed or adenomyosis, those types of things, that by taking care of that disease, even though there's endometriosis still present, that may be enough of a pain improvement that they do okay. I think just making sure, doing what we can to make sure they're informed about that, but still understanding that that patient gets to make their own decision.
Yeah, I think, again, going back to all of the endo warriors, that they, even for me, when I have conversations, they are very, very informed, and I really like that. So I think something that the endo support groups have advantage in is being able to share that information with each other. So yeah, that'd be great. So another question, we are almost out of time and we have a lot of questions coming in. I really appreciate everyone chiming in. So another question that I have here, do you have any idea on how to effectively expand endometriosis education for general gynecologists? Is this something that ACOG should be involved in? Can we as patients and advocates do something to push for this?
I think in general, the way to make the biggest impact is really through the residency programs. That is where the doctors learn their approach to treating endometriosis. If they don't learn it in residency, they really have two options. And the hard part is within an OBGYN residency, it is probably the biggest and broadest residency out of anything. You think of everything that an OBGYN resident needs to learn in 4 years between pregnancy care, delivering babies, preventative medicine, women's health, and all the surgical things that we deal with. It is a huge volume of information that doctor is expected to come out as an expert. And once they leave residency, you now have a provider that is relying on what they learned in residency. And if they're not comfortable with their surgical skills, or they don't have a partner that they can go out and mentor with, it's really difficult for them, I think, to advance their skills to the point where they're going to feel comfortable treating advanced endo. Now, I've seen a lot of, even my own partners in the past, though, that as we've talked and as we've managed patients together, they will start to move toward a more excisional approach of endometriosis. But they're more comfortable with the stage 1s and the stage 2s. They're not necessarily comfortable working around the ureters or the bowel that are deep rectovaginal. And that's understandable, but at least there are more doctors that in their own practices, they're pushing to learn a little bit more and become a little bit more comfortable. But to really get to the level of full, complete excision and advanced adhesion work, I think it really is going to take either a fellowship training or for a provider to kind of leave their practice for a period of time and go do extra training in it through an unsponsored fellowship type of thing. And the hard part is you're coming out of medical school, you're coming out of residency, you've jumped into a new job, you have your student loans and all the costs of practice. And it really is just not feasible for a doctor to drop their practice for 3 months or 6 months and really try to jump in and learn how this needs to be treated. I think the biggest impact on the advanced stage endometriosis would really have to come from a residency standpoint. And even within that, it's going to take some adjustments within the residency training. There's been some chatter over a number of years about potentially having OBGYN residents choose an obstetric track or a gynecology track in their last year or two of residency. Just with the difficulty of endometriosis surgery, the advanced stage disease, I think it's just tough to learn unless somebody's super committed and takes the time out of starting a practice to get into that. But I have been a little bit reassured talking with some of my old colleagues to see that they are trying to push and realize that excision really is probably the best way to treat the endometriosis. And they are moving into excision of some of those stage 1 and stage 2s. And then as they get more comfortable, they're moving with some more complex dissections, but it's going to take a long time to get there.
Thank you for that. I have one more question. Because we're getting close to that time, but I want to thank everyone for joining. So that last question is, do you have any advice for managing your relationship with your regular gynecologist after choosing to go elsewhere to a specialist for endo care?
I think to me, and this is often brought up in some of the support groups, I think to me the best way that I have read of patients approaching it is just to sit down with the provider and say, look, I've been with you for a long time or whatever period of time, and I really appreciate your willingness to help me through this. I appreciate the work that you've done in trying to find ways to help me feel comfortable. But the things that we have tried, I'm just not where I need to be. And to let them make sure that they know that you appreciate their efforts, and that you appreciate them as a provider and a doctor. And because of that effort and their willingness to work with you over the years, that you would really like to continue on with them, but you feel like you're at a point where you need to at least get a second opinion on what may or may not be there and how to manage it. Always recognizing the efforts that are made and appreciating the efforts that are made. If there is a relationship established, really hit home on that relationship, because between providers and patients, there is a good relationship, or there should be. And if there is, to recognize that. And I think those providers are more willing then to kind of continue to follow up afterward. But, understanding that you appreciate their efforts that they've made on your behalf, but also understanding that you're not where you want to be, and that you need to check into another option that might be able to help you get there.
Thank you. That's great advice. So that is actually all the time we have for today. So I know we didn't get to all the questions. Please feel free to email them to me if you'd like, and I will do my best to see if we can get Dr. Arrington with some free time to answer those personal questions. For those of you that tuned in a little later and missed the beginning, don't worry, I will be posting this on our YouTube channel as well as on our website, so that will be up by the end of the week today, or this week. So you'll have that replay ready by Friday. And like I said, if you have any questions, feel free to email me. I'll go ahead and type my email in the chat box very quickly for you all. Again, I want to thank you, Dr. Arrington, for coming on and giving us an hour of your time to share and learn about informed consent.
You're welcome. I really, really appreciate these opportunities and little things that educate and teach. This informed consent is a critical one in the world of endometriosis, and hopefully that's something that we can continue to make progress on.
Yeah, I totally agree with you on that. Well, with that said, I want to thank everyone for joining us. I hope everyone has a great day. And if you're in California with all this wind, I hope you stay warm and cool. I know we have a few of you from out of state and other countries. I hope you stay nice and warm too. For those of you that have great sunny weather, I hope you get to enjoy that. Yeah, well, all right. I hope everyone has a great day, and we'll see you hopefully soon. All righty.